From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to this author interview from the JAMA Network. This is Dr. Adamson, the web editor for JAMA Dermatology. Chronic skin disorders in children frequently are visible and can cause stigmatization. However, little is known about the extent of this stigmatization and how it relates to disease visibility and its impacts on other aspects of quality of life. In a new study in JAMA Dermatology, authors performed a cross-sectional study across 32 pediatric dermatology centers in the United States and Canada to investigate the extent of stigma, dependence on disease visibility and severity, and the relationship to mental health and quality of life in chronic pediatric skin disease. Dr. Amy Paller is board certified in dermatology, pediatrics, and pediatric dermatology. She's the Walter J. Hamlin Professor of Dermatology and the chair of the Department of Dermatology at Northwestern University Feinberg School of Medicine in Chicago, Illinois. She's the first and corresponding author of this new study and is here to discuss this work. Welcome to the podcast, Dr. Paller.
Thank you, Adewole.
All right. So, for those that don't know, tell us a little bit about your role or your many roles.
Well, I wear many hats. I am chair of a department. I am a pediatric dermatologist here at the Children's Hospital. I run a clinical trials unit focused on inflammatory skin diseases and genetic disorders in children. And I also run a basic science lab, as well as direct our NIH-funded Skin Biology and Diseases Resource-Based Center. My role here in this particular study, though, was being the captain of a study through the Pediatric Dermatology Research Alliance, which was formed now more than 10 years ago. And I'm just delighted to be part of this and to have been a leader in PEDRA, this organization.
So as part of this organization, you do a lot of different studies. I'm sure this is one of many. But what made you decide to study this specific issue of stigma? Was there just not a lot of work out there about how skin disease affects how children feel?
Yeah, that's a great question. And it actually was the coming together of two events. We've known for quite a while that people don't take skin diseases very seriously in contrast to other chronic medical illnesses. We've also been somewhat discouraged at the response of, for example, industry or regulators in terms of the importance that we all witnessed on a daily basis in taking care of children who have skin disorders, that these have a tremendous impact. They may not be life-threatening, but they may be life-altering for the majority of children. But we had no data to support this. And in talking with, for example, some leaders of industry whom we wanted to move forward in trying to develop new ways to treat, and this was several years ago, we found them saying, we need numbers. We need something that we can go to regulators, that we need something that we can go to our boards. We need to have support for partnering with you to develop new ways to turn around these chronic skin illnesses in children. Now, at the same time, we happen to have an NIH-funded U19 grant that was allowing us to look at tools called PROMISE tools. This is the patient-reported outcomes measurement instrumentation system tools that were developed with NIH funding and were in wide usage by other specialties for measuring in children and adults and in caregivers' perspectives the various domains that might be altered in disease. Through the U19 grant, we developed two new scores. One was to measure itch, which had not been part of the toolbox in children, and the other was to develop a score for stigma based on a very neurology-centered stigma tool that was available. We made it generic. We added 6 questions that were skin-specific, but we also calibrated the tool not only then in the children with neurologic diseases, but also in cancer and skin diseases. So we had created a tool to measure stigma that not only would look at the range of stigma in children with skin problems, but could allow us to now and in the future, as it rolls out, compare the stigma in children to those of other chronic diseases on this type of a scale.
And I think it's probably important that the audience appreciate that, just because we might know this in adults have tools to measure, say, stigma or itch or pain, that doesn't necessarily mean that those same tools work in the pediatric population.
That's right. Any tool to be validated in the pediatric population has to be tested in that population and often adjusted for comprehension and adjusted so that it makes sense for the pediatric population.
So you all had a meeting where you discussed this idea of stigma and you were able to adapt these tools through Promise. So in Promise, there are a lot of different tools that you could have, little measurement tools that you can use. What specific tools did you use for this study and why did you pick those?
Well, I took this idea back that stigma might be a good focus for measurement of this group, and collectively, the Pediatric group decided that this would be their big study, the first study that we would do and try to get as many centers as possible working together to discover and to provide data. This is the purpose of a Pediatric Dermatology Research Alliance, that we can come together and create studies that look at larger numbers than any of us can do with our single institution. And that's exactly what we did. We decided to choose tools specifically, and of course we can't have too many or it would be unwieldy, that would look at stigma in children in relationship to their mental health, their social and their psychological well-being. And that's exactly what we did. We selected tools like a general tool that looks at aspects like anxiety and depression and peer relationships. And we also looked at the stigma tool. We chose to use a quality of life measurement that's been used in adults frequently, but has had less experience in children, and that's one of the Skindex tools that was developed for pediatric patients.
How did you decide which patients would enter into the study? Because there's, hundreds of different diagnoses that pediatric patients get. What was the inclusion criteria about who would be included or approached to fill out these tools or these surveys?
We wanted this to be very much a representation of what we see in our clinics and real world. So the first real world aspect of this is that we were doing this in the middle of clinics. And the reality is that we would have liked to have enrolled everyone who met criteria, but that we're kind of busy in our pediatric dermatology clinics. And there were some clinics where we had the personnel or we had a little bit of more downtime to enroll, and others that were more difficult. So we enrolled when we could. And what we specifically were looking for is anybody who had at least what we would call something that was visible. So if they only had lesions, for example, in the buttock area that would always be covered, we wouldn't enroll that child. And we also wanted to enroll people who had active disease.
Hmm.
So we had an either or of visibility or moderate to severe disease that we thought could impact them. So it wasn't everybody, but it was a large swath of the patients who came into our clinics. We also wanted something with chronic disease. We didn't want something that had just popped up in the last month. So we also had criteria for how long the disease had to be present. We said at least 6 months.
Okay. And it didn't matter whether they were undergoing treatment or not.
Well, if they were undergoing treatment that was highly successful and they didn't have much to see, then obviously we didn't include those children. But of course, we had several children who were undergoing treatment but still only partially improved and thus could be part of this study. I will add that it was quite a challenge because we like to use tools for determining severity that are validated. But in this case, because we were taking such a broad swath of the population and wanted to look across chronic diseases, albeit clearly with some that are more common and then are going to make the majority of the various diseases enrolled, we had to develop a scale that just looked at self-reported, proxy-reported, physician-reported severity. And so we just picked a scale of clear, you weren't there, mild, moderate, severe in terms of deciding what the severity was. And similarly, we developed a scale for visibility that was assessed by self, by proxy, by physician
Mm.
as either being visible at all times. That is, it's on the hands, it's on the face, or being just visible partially when clothed so that depending on the season, they might be able to see it or not visible.
All right. So you were able to get 32 different centers involved in the study in both the United States and Canada. And you enrolled over 1,600 patients ultimately. That's correct?
Yeah, we had 1,671 who were able to be in the study, and very little missing data, actually, because, of course, we did this in person. It was a single visit at which we captured this data. I will say that another challenge for this study was that COVID came.
Mm-hmm.
And it came right in the middle of when we were doing the collection. And we had to think about whether to just barrel through. Of course, we weren't even seeing people in person for a while there, or whether to take a hiatus.
Mm-hmm.
We thought long and hard about this because we were trying to capture issues that could be impacted by being in school.
Mm-hmm.
We were trying to capture issues that, if there were mental health challenges, could be impacted.
Mm-hmm.
And so we decided to take a break of several months when the children were out of school. And we then came back to the study when children were back in the school setting and continued it. So would have loved even more patients, but that got in the way.
Do you think that COVID had an impact on people's mental health, just absent of skin disease, whether that might have affected some of the data that you ended up collecting after COVID occurred?
We worried about this, and so we specifically compared the data we got from the subset that was enrolled after COVID hit and when kids were back in school with the data from the earlier period before COVID was anything anyone had even heard of.
Mm-hmm.
And there wasn't any difference.
Okay.
So we felt comfortable that it had no significant impact.
Okay. And so, what were the main results that you found? How stigmatizing were some of the disorders that ended up being present in patients in the study?
These are stigmatizing disorders, and using this newly developed tool with its scale,
Hmm.
which of course is just looking across these chronic medical conditions, we found that skin disease was right in there. It was very close to the middle in terms of where these fell, the middle reflecting moderate stigma within this group. Overall, if we exclude those who we felt had no or very little stigma based on score, 73% of all of the children had evidence of stigma, and 44% of them had what we would call at least moderate stigma, 8% high levels of stigma using this scale across this variety of chronic disorders.
Hmm. And what disorders were included in the study? I know you don't want to name all of them, but some of the more common ones.
Yeah, I think it's important to point out that we had a lot of the common skin diseases here. So acne was one that was very highly enrolled. We also had a lot with atopic dermatitis, with alopecia areata, psoriasis, the ones that we see most commonly.
Vitiligo. Hmm.
Yeah, vitiligo is in there too, a little bit less, but vitiligo was another one that was seen in large numbers of patients. And what we found, and by the way, we'll probably write up some more specific studies related to specific diseases in the near future. But what we found here is that across the board, if you look at the mean for each of these individual diseases, which we published here, we are in the realm of the middle of this pack
Hmm.
of chronic medical conditions in terms of the stigmatization.
Hmm.
Not surprisingly, there were some diseases that had relatively higher mean stigma levels, like epidermolysis bullosa,
Hmm.
ichthyosis, these really debilitating, highly visible disorders.
Hmm.
But there were some that were a little bit surprising. Smaller numbers need a bigger study now to further verify and also look more closely. But hidradenitis suppurativa, hyperhidrosis. And I want to just mention hidradenitis suppurativa in detail here because this is a disease that largely occurs in areas people can't see. We're talking about the axillary area, the groin area, and yet incredibly stigmatizing. And when we broke down the questions into ones that reflect internal stigma, that is, as perceived by the patient, as opposed to external stigma, ones that are really experienced by the way they're treated in life, the questions that were really, really high were all of this internal stigmatization. So not so much because people see things and respond, but just because of the way people were experiencing responses of others, the way they were perceiving them.
And one aspect of the study I found interesting was around bullying and parents being aware or not aware of bullying. You mind just telling the audience a bit about that finding?
Yeah, we in the end decided not to put in any particular bullying tools to assess here in this particular study, but we did ask the parents if they had any knowledge that the child was being bullied. And of course, we know that there are many children who are ashamed and don't even tell their parents about this. But we found that 29% were aware of bullying in their child. And not surprisingly, the relationship with stigma was very high in these patients. We had a Cone score of negative 0.79, reflecting the fact that this is a group of children who are experiencing severe stigma for the most part.
This is like a kind of 10,000, 30,000 foot view of stigmatization across many pediatric dermatology disorders. Is the next step to delve deeper into some of these individual diseases? What now? What is Pedra's next collaborative endeavor?
Well, clearly, we do want to flesh out the data better across all of these diseases, and maybe particularly some of the ones that had smaller numbers and yet suggested fairly high impact of stigma. I think we want to really spread the data because it's so important now to recognize how much these skin diseases are influencing the psychosocial development of children. And it's not just having better treatments, but it's recognition of this problem.
Mm.
It was interesting to look at the differences between the way physicians and the children themselves viewed their own severity, viewed their visibility, and how that impacted the scores for stigma that we got from the children. And it told us that the physicians weren't really so much in tune with what's going on. And that may be because we really pay a lot of attention to what we see
Mm-hmm.
in front of us, and in a busy visit, don't ask enough questions about the impact. But we want to get stigma in there because stigma had this incredibly high relationship with quality of life. So just asking the question, how's school going? How do you feel that this is impacting your child? And we do have short forms for this stigma tool that can be administered in less than a minute if there's a concern about there being a stigmatizing situation for that child. I think there's also the opportunity here to develop better tools for connecting with psychologists and making it easier for families when we do discover that there's a mental health issue, whether it be stigma alone or whether it be anxiety, depression, and get some help for these children beyond just treating the disease itself.
Well, I'm Dr. Adewole Adamson. I've been speaking with Dr. Paller about stigma and chronic skin disease in pediatric patients. You can find a link to this paper in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening. Catch you on the next episode of the JAMA Dermatology Podcast.